For everyone with an interest in MASH, or more broadly, steatotic liver disease, Surf's Up. Season 5, Episode 4 of Surfing the MASH Tsunami. Our look at updates on epidemiology and what it might mean in the world as we go forward starts now.
Today on Surfing the MASH Tsunami.
2 decades ago, when I started this field, it was almost 25, 30 years ago, we were not aware of the burden. And now we know that it's not just the prevalence that is high, that it actually leads to bad outcomes.
The patient-reported outcomes couldn't be underestimated because at the end, that's what counts for a patient. Coming up with meta-analysis data for that, very impressive. The financial aspects are very different from country to country. The question is if we don't act on that highly prevalent disease to a certain level, where of course continue to incur costs.
One of the sections within the paper referred to the fact that women over 55 are in one of the liver transplant risks now. Is there an opportunity here to liaise with menopausal health, to put women on a screening program rather like we have cervical screening, breast screening, particularly when they hit menopause?
The numbers that you've been producing over the years suggest a rate of increase of disease where if we could simply flatten the curve, that would be pretty heroic, given the low level of attention and resource that it gets right now.
It's great to have guidelines, but if nobody's following them because they're not being implemented, then it's all for naught. We have over 100 some guidelines from across the globe that we put together and then summarize these in an easy to access sort of way for everyone so that we can have the original guidelines available.
Every week, a global community of steatotic liver disease stakeholders comes together to explore the most critical challenges in diagnosing, treating, and developing medications for patients with MASLD and MASH. Join hepatology researcher and key opinion leader Jörn Schattenberg, liver health advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guest, hepatology researcher and key opinion leader Zobair Younossi, as they discuss recent epidemiological estimates of MASLD and MASH, particularly related to type 2 diabetes, this week on Surfing the MASH Tsunami.
Remember to stay tuned after this episode for our first question of the week.
So there's a lot that's different about this week for us in no particular order. We have Jörn with us for the first time in a while. Jörn, how are you doing this evening?
I'm great, Roger. Thank you. And it hasn't been that I didn't want to join you. It's been just particularly busy those last days. Among the highlights, of course, being able to have dinner with Zobair 2 weeks ago. Been traveling a little bit and working, so it's good time.
Good, and it's good to have you back. And no one can see this except for us, but you're recording from upstairs in your home in Mainz, which is something I don't think we've ever seen before. So a new ambiance, lending spirits, all that. And Louise is back from Australia, having flown over last night before. Louise, how are you doing this evening?
Yeah, I'm very well. Arrived back this morning, 5 a.m. sharp. To a little bit chillier weather, but nice to be back in London.
So what is the temperature in London right now? Or actually, you're down south, wherever you are right now.
Down in Taunton now. I've got a scanning commitment tomorrow. Probably only around about 9 or 10 degrees, but it was sunny, so that had one similarity.
Or another similarity, if it gets down as low as 5 or 6, then it'll be 42 or 43 Fahrenheit. Whereas the other day it was 42, 43 Celsius. So you just have to change the scale. The number stays more or less the same. And then we're extremely fortunate to have with us today Zobair Younossi. Zobair, how are you this afternoon?
I'm doing good, Roger. Thanks for asking me to participate.
Well, thanks for joining. I've not had the good fortune to have dinner with Zobair recently. I guess the last time we caught up was in Boston. Okay, so with that, why don't we just dive in? What we're going to do today is Zobair and a colleague posted an article recently in Diabetes Spectrum, which was an update on some epidemiology numbers, but really, I think, an effort to discuss the totality of the disease for an audience that might not know it as well or in the same way. So I want to talk about the epidemiology. I want to talk about the joint focus on diabetes and whatever else we get into as we go along. Zobair is never short of topics he is capable of and comfortable discussing and educating on. So I think this will be great. With that, why don't we just get started? Simple groundbreaker. One good thing, personal or professional, that's happened in your life in the last week? Brave one, go first.
If I should start out, again, I mentioned a couple of travels, trip to Washington, which I was able to meet up with Zobair. Personal, very entertaining, and thanks for the dinner again, Zobair. Professionally, I have to say I've been very excited about a press release. Not sure it has sunken through to everyone yet. There was a press release in a phase 2 MASH trial result from Boehringer Ingelheim, survodutide, phase 2 trial results 2 days ago, and that read very well. I mean, it's a press release, so we don't have the full data set yet, but the treatment response was something like 83% over placebo 18% with a combined GLP-1 glucagon receptor. Sounded a little bit like hitting it out of the park, so we'll have to see what comes out of that.
The measurement was MASH or fibrosis on that, the 83 to 18?
I have to go back and look. That's the top line. I'm just reading off the internet now. It doesn't detail all the results with regards to histological improvement. It wasn't fibrosis. It was improvement of MASH versus placebo, which is actually a 64% difference. So improvement of MASH. And again, I think we're going to see full data sets in one of those upcoming conferences. So there's more to be on the lookout for.
Excellent. So while that's not exactly the topic of Zobair's paper, I suspect we might get to that, since one of the questions I'm going to be asking people a lot this year is how they see the advent and indication of the incretins, even if not for MASLD or MASH, coming into play as more people take them for obesity and for diabetes. That's a question we've talked about a little bit. And with the increased consumer publicity in the U.S. for these agents, you can't turn on a TV station right now and not see an ad for somebody talking about the wonders of GLP-1s, and therefore why you should get a teledoc to write your prescription for it. I suspect we'll get there. That's great, Jörn. Next up, good news, Groundbreaker.
Oh, well, I'll jump in purely because it's not really about me. I saw a post from Fatty Liver Alliance where they sort of joined unexpectedly NASH Knowledge's virtual golf that Gina and Anthony Velotti run. And it was really, really nice and heartwarming to see the reactions because they weren't expecting him. And often charities may not always support other charities in the same field in the same way. And so I was really quite touched. And Gina's face when they were talking about it, and Tony's when Michael Patel arrived was nice. So it was a heartwarming story for the week about the support that other liver charities give other liver charities. So it just made me smile.
Yeah, I spoke with Mike right before he left. He was really excited. You know, they've developed quite a relationship. They joke about how Mike is Tony's adopted son, although they're not that far apart in age, frankly. So I thought that was going to be fantastic. And yes, I agree. Zobair?
I think, it was the highlight of the month that I saw Jörn, of course, but but at the same time, I think in terms of sort of the efforts that we are seeing across the field in terms of everyone is hoping to increase awareness about this disease. I think that's really heartwarming for me because for many, many decades, MASLD, NAFLD, whatever you want to call it, has been really neglected. By gastroenterology and of course, non-hepatology sort of specialties. And there is an effort from all stakeholders, from patients' perspective, from providers' perspective, and from drug companies and even policymakers to promote more and more education about this disease and the importance of recognizing the burden of MASLD, not only in the United States, but globally. And there are a number of things that I've seen over the past month that gives me hope that we will get that awareness and the recognition that this disease really requires for us to make a difference.
Yeah, I agree with that. We're actually starting to see more mass publicity, I think, in the States, Zobair. Not yet on the level of all the teledocs prescribing the ED meds and the GLP-1s, but starting to see more and more stories about MASH, about MASLD, usually using new nomenclature, and its importance. I think some of that is probably in the run-up to the resmetirom PDUFA date, although I'm not sure Madrigal is driving all of it. I think some of it is about the increased focus in the aftermath of nomenclature, and some of it I think is just the work that you guys have been doing for years. We've been doing it, really, you folks have been doing for years, to inform the broader medical public and even the mass community about exactly how widespread this disease is, which will take us back to your article in just a minute. So I couldn't agree more. Professionally, I guess my note is people continue coming back to this podcast, which is great. Personally, I'm being treated at once for two bad calf muscles. Well, bad calf muscle on one foot and Achilles on another. I was introduced to a device called an allergy. I don't know if any of you ever heard of it. They literally zip you in. They put pants around you. They zip you in. They blow up the pants with air. and reduce it to be a percentage of body weight, at which point you can run faster than you ever could in your life, or at least at this age of my life, because I'm only running at 75% of my body weight. So I wind up at the same time improving my calf muscles and feeling like I'm 25 years younger. It's a great experience. Just don't get me out on
it. Sounds like an interesting one, Roger.
Yeah, it is, Jörn.
We need photos.
Well, the funny thing is this, while you're running...
They wasn't gold lame, perchance, was it?
No gold lame. Not doing that. Louise, if you're going over 3 miles an hour, you can put on a video and watch how your feet are moving, which leads me to believe my running motion isn't nearly as interesting as I thought it was. It's certainly not as high stepping. And when you're under 3 miles an hour, if you're walking, you can do a gait analysis. How long are your steps? Which side are you misplacing your weight on? All this for data geeks like me. I can sit in this thing for half an hour and spend half my time feeling like I'm flying and the other half of the time seeing data I never would have seen in my life. It's just a great experience. I do it twice a week. It's become one of the highlights of my week, but not to the same degree that recording this podcast is, obviously. With that, why don't we go on? I think, Zobair, you kind of went towards where my introduction was going to go, which is exactly that we're seeing increased awareness about the disease, both more information and information distributed more broadly, and to the point where people are starting to think they can actually do more about it. All good things. So against that backdrop, Zobair and Linda Henry put up this article on Diabetes Spectrum recently that I guess Scott Isaacs, first and foremost, was posting. I saw 4 different posts from Scott on the same day on LinkedIn on your article, which is what led me to say, okay, probably a good time to talk about this. Unfortunately, couldn't access Scott to join us, which would have been fun. With that, we try to talk about epidemiology in this podcast once a year, and this felt like a good time, and this felt like the right article. So with that, let me just start by turning the floor over to you and take a few minutes about what the impetus to do this particular piece was and what people can learn by reading it that they might not have known previously. And then we'll come back and ask questions and sort through in a little more detail. The floor is yours, my friend.
Thanks, Roger. Yeah, I think that this was a review article, which was a summary of a large body of evidence that's being generated. The bottom line are a couple of things. One, that the prevalence of MASLD in the general population globally has increased now to about 38%. So this is a large increase. But if you actually focus on the type 2 diabetics, these are individuals who are at highest risk not only for having MASLD and MASH, but also higher risk of having adverse event, including mortality. The latest meta-analysis that we performed, and it's currently being published, is that prevalence for MASLD is 68%. But if you look at MASH, in the general population, the prevalence is about 5 to 7%, and the type 2 diabetics is about 37%. And about a quarter of those patients actually can have advanced fibrosis. So that tells you that the prevalence of MASLD in general has increased, and then among those who have really the most severe form of metabolic disease, type 2 diabetes, is even higher. And both the visceral obesity and type 2 diabetes is increasing across the globe, so these rates are increasing. We've done another meta-analysis that's currently being peer-reviewed, which is looking at the prevalence of MASH cirrhosis globally. And that's also interesting because the prevalence is somewhere between, the general population is about 0.3 to 1.8%. So that's a large number of patients when we are looking at this. And the enhanced data set from the United States, the prevalence of NASH or MASH cirrhosis was about 1.8%. Now, if you look at those who already have NASH or MASH, and we look at the prevalence of cirrhosis, of course, that's higher. It's about 5 to 6%. But even in general population, the numbers are pretty large. So that's on the clinical burden of disease. We've also been looking at the humanistic burden of this disease, meaning patient-reported outcome and quality of life. And there is a substantial body of evidence that quality of life of these patients are impaired, which is probably primarily driven by fatigue. We have a paper currently that's actually being resubmitted looking at fatigue in different liver diseases. And in fact, the liver disease, it's one of the fatigue is a predictor of bad quality of life or other patient-reported outcome. And that's not only important from a patient perspective, but it's also important from a societal perspective because fatigue is a driver of work productivity or lack thereof, which means that the indirect cost associated with MASLD could be substantial because fatigue drives a lower worker productivity, which results in significant indirect economic loss to the society. Now, that is in addition to the direct cost of MASLD, which is another project we are currently doing and finalizing. So those are the different aspects of the burden of this disease. When you put this in the context of global burden of disease analysis that we've done, it shows you clearly that in most regions of the world, when you look at GBD data, that the prevalence in mortality from MASH and MASH cirrhosis and MASH liver cancer, or HCC, is actually showing an increase in terms of annual percentage change. So every year MASH is actually increasing. And on the other hand, if you look at, for example, HCC, cirrhosis or HCC, especially HCC, in a lot of regions of the world, the burden from hepatitis B-related HCC is actually declining. So there is improvement, probably related to vaccination and other things. But for MASLD and MASH, they're increasing. And this is also highly driven by both lifestyle of diet, but also inactivity. In fact, our analysis of GBD from Middle East and North Africa suggests that it is driven by, the metabolic risk factors and diet associated with this, but significant inactivity. That's part of lifestyle that needs to be addressed. So lots of things interconnected, clinical outcomes with humanistic outcomes to the economic outcomes. And that what we saw 2 decades ago, when I started in this field, that was almost 25, 30 years ago, we were not aware of the burden. And now we know that it's not just the prevalence that is high, that it actually leads to bad outcomes. And that's liver cancer. Currently in the United States, it's one of the dominant reasons. In fact, the number one reason to be on the transplant list for liver cancer in the United States is NASH or MASH. So it's the second indication in general for liver transplant in the United States, and I suspect in a number of different parts of the world. So this disease's burden is so wide and multifactorial that impacts every aspect of the different types of outcomes we're looking at.
Roger, if I may just say, Zobair, congratulations on the work you've been doing over decades now for this, and really with your team together coming up with a meta-analysis from different parts of the world. I always find that is amazing how you oversee all these different developments. If I summarize it, the clinical burden, I think you help us as a clinician to actually look into the right direction, right? So you educate us as physicians on where the risk factors and the at-risk populations are, and we're moving that way. I mean, we're trying to focus on patients with diabetes that are more advanced from the hepatologist perspective, and we're trying to educate the endocrinologists about the prevalence in their practice, and GPs, on the other hand, helping them with the prevalence in their environment and help to shape patient referral pathways. So I think that's very important. The patient-reported outcomes couldn't be underestimated, because at the end, that's what counts for a patient, right? How do they feel? And you're able to measure that across all these big populations, coming up with meta-analysis data for that. Very impressive. And again, congratulations. The financial aspects are very different from country to country. I know we've discussed in the past a cost of inactivity. So the question is, if we don't act on that highly prevalent disease to a certain level, we're of course continue to incur costs. And I think that's something you also included in some of your models, or you've been discussing with the team. Is that right?
Yes, Jörn, thanks for reminding me of that. That's so important to actually assess and estimate the economic burden in each country based on the reality of that country. So we've been creating a Markov model now for many years that needs to be updated, and the data need to be perfected as much as possible. So we have a very, very good model at the moment. We've just finished actually assessing the economic burden of MASLD in the United States, where our plan is to actually do 6 or 7 countries, including Germany. Jörn and Michael Roden and Frank Taki are all involved with the German model with us. We go to Spain, we go to Brazil, we go to Saudi Arabia, Japan, potentially Italy, and other countries will come. But I think it'll be important to look at each country, that if you really don't, it's really what I call it is the not only cost of inaction, but what is the economic burden of the disease. And that means that if you don't do anything as a policymaker, the cost of not doing something, just the direct and just some of the indirect costs. The indirect cost that we can measure is work productivity loss, as I mentioned before. That actually is enormous for countries, and the countries need to have policies to address this and promote education about this disease, so that we can, remember, if the prevalence of MASLD is 38%, the number of patients that actually will develop cirrhosis in terms of percentage is relatively small. But because we're dealing with such big group of patients with MASLD, that small proportion still is a huge number of population that we need to deal with. So that is really incredibly important for all stakeholders. In this context, for the policymakers, payers, especially, and payers are different in different parts of the world, to make sure that we address it, that we have policies that will actually recognize MASLD as one of the most important non-communicable diseases that's outside the infectious diseases that we talk about, but it be recognized as one of the important non-communicable diseases in the world.
So Zobair, just follow up quickly on one small part of that. Going back a long time ago, I remember one of the discussions about aggressive treatment of hypercholesterolemia back in the 80s and 90s being that the number of patients that would benefit at a cost per patient up against what you'd have to spend to really eradicate the problem didn't make sense economically using the metrics people used at that point in time, because the cost for every case that advanced to, say, some cardiovascular event versus how many people you actually had to treat for cholesterol to get there, those numbers were more balanced. Here, my guess is that if you're talking about 1.8% of the population with MASH cirrhosis, that the cost of treating those 1.8 million people is so exceptional on an annual basis that even if you had to surveil 100 million people together, the numbers would actually work out. Do I have that roughly right in my mind? Does the scale work that way?
Well, yeah. I think what you need to do after establishing efficacy and effectiveness of any drug or any treatment regimen, you have to establish cost effectiveness. And cost effectiveness of the drug would be established based on value equation, which means that it is not only about outcome. We have surrogates of long-term outcome here. We use fibrosis and resolution of MASH as a surrogate of long-term mortality, liver-related mortality. But it's the cost of the drug and cost of the disease over the quality of those years that actually are added because of the use of the drug. So we use something called cost efficiency assessment or cost utility assessment, where you take all of these things into consideration. Now, I can tell you that when you look at, say, the analysis that was done by ICER in the United States for the two drugs that were out there, the resmetirom from Madrigal and then obeticholic acid, that's not currently being considered for NASH. At least the ICER analysis and then subsequent analysis suggested that if the drug is priced well, and the efficacy data that we're seeing currently is going to also be seen in the real world setting, that this drug will be cost effective. So from a society perspective, it's, are you meeting, if you're using a drug, are you meeting what's called the willingness to pay threshold for that country? So the willingness to pay for this country is that in the United States, in general, $50,000 for each additional quality adjusted life years is accepted as a cost effectiveness. Now, that you have to remember that even in the United States, there are diseases that actually even much higher threshold has been accepted. $200,000 to $250,000 per quality, for example, for some cancers is acceptable. Now, that may not be the case in another country like in India or even in UK. The thresholds are lower there. So when you're actually looking at the drug approval in terms of efficacy and safety, then at some point one has to do economic analysis and show that from a societal perspective that is actually acceptable. Now, that's also different than sort of a budgetary perspective from a payer's perspective. So everyone has to do their own modeling, and I think it will happen. If you remember in the old days of hepatitis C, it wasn't actually cost effective to treat patients with the drugs that we had. But as the efficacy increased, safety increased, and drug prices fell, it is no doubt that the treatment of hepatitis C patients are going to be cost effective. So we're sort of this first steps towards that goal. But I have no doubt that even with the drugs that are at the sort of verge of getting approved, that we will have cost effectiveness from a societal perspective. And then we have to convince our payers, which is much more complicated in the United States because there's so many different types of payers, to convince them that for their population that they have under their plans, that the drug will save lives, will save complications of cirrhosis that are quite costly, or liver transplantation. So that has to be done, and it's something that all of us, including Jörn and others, are playing a part in.
I was amazed by this piece of work, and congratulations to both Zobair and Linda Henry, who I think was the co-author with you on this. And it makes frightening reading if you break it down into just its figures. And when Zobair was talking there about the cost, there's a section here that one of the studies that you use, that NAFLD amongst patients with type 2 diabetes in the US could lead to $5.8 billion 20-year cost 65,000 liver transplants, 1.37 million cardiovascular-related deaths, and 812,000 liver-related deaths. These are frightening figures, and we're nowhere near looking at how we're going to stop the Titanic from moving. We're not really spending the time in prevention, earlier diagnosis, earlier assessment for poor liver health before it leads to some of these complications. So just picking through the document was fascinating. And from a patient's perspective, it's not just the patient who suffers, it's the quality of life of the person, the people around that patient, trying to support them, the extra days they take off from work to support that patient. If I look at the Australian models, moving around the country to get FibroScan in limited areas, that takes an awful lot of resource. So I'm hoping that this sort of epidemiological data now really pushes the WHO to really focus on giving it NCD status, because that will help focus it in low middle income countries where some of this is a real problem. So it's a great piece of work. It is frightening. It's not quite Halloween yet, but it's an early piece. It was startling.
You're right. I mean, the purpose of that was for us is to just highlight the fact that the burden is important. So when you look at patients with diabetes, no one will question their risk for eye disease, for retinopathy, or kidney disease, or cardiovascular disease. However, the liver disease has been and continues to be ignored. And I think that is really the point to make, is that when you look at this group of patients, they can actually drive this important outcome that could be much more costly from a society perspective than even other complications of diabetes. And this is not to replace one complication with another complication or rank them, but just to raise awareness that when you're doing your annual check and there is, even in primary care setting here, if a patient has diabetes, there is no doubt that you're going to be sent for a retinopathy check, an eye check, or get a creatinine assessment for a kidney check. But no one is really thinking about, well, maybe I should actually do a FibroScan or some sort of a test to see what the liver status is to the diabetic patient with that high number. And I think that's the point of this, is to just make sure that we assess those patients who are at risk to see if they're considered quote-unquote high-risk MASH or high-risk MASLD or not. And that's done with the non-invasive tests. And very easy to do. Even if you don't have a FibroScan, you certainly can do a FIB4, which is available by just simple blood test and some demographic data. And I have to tell you that looking at some primary practices where I practice, you don't even have those labs done so that you can calculate the FIB4 by a lot of the practices. So there's got to be a more awareness even at that level. So we're hoping that all of us together can actually help stakeholders. And I think you're absolutely right. When we talk about indirect costs or intangible costs of this disease, we're not actually calculating the cost to the family and to others. And this is really the purpose of this, not to scare people, but to actually raise the reality that this disease is going to become even more prominent if we don't deal with it now.
That's a very important point. And I think it's both towards, the payers, the regulators, the colleagues, where you say the people that are responsible for implementing a FIB4 to be able to use it as suggested by the guidelines and actually refer patients, getting in the mindset to be ready. And I think the work that you and your team have been doing around the numbers really support that effort. Back to you, Roger.
I think that's right. So, Zobair, a couple of questions. First of all, it seems to me that the numbers that you've been producing over the years suggest a rate of increase of disease where if we could simply flatten the curve, that would be pretty heroic given the low level of attention and resource that it gets right now. What feels to you like a realistic goal for the next 2, 3, 5 years?
So I think we have sort of multiple level of parallel attempts that we have to make. At the primary care sort of level, they need to be aware of, if nothing else, to risk stratify patients. They don't have to necessarily take care of those patients because a lot of the primary care physicians, general practitioners in the United States, they're afraid that the number of patients they're seeing and the limitation on their time is a deterrent for them to do this. We need to educate them at that level. And the gastroenterology and hepatology side is that, for those patients that we need to either treat with new drugs when we have, or first of all, to have an effective lifestyle intervention in place, that would be important. In the clinical side, it's really multidisciplinary sort of approach to this and care pathways that will bring in multiple care providers. I'm not even saying that there has to be nutritionists, there has to be a behavioral health specialist, and maybe in a virtual sort of umbrella that will deal with this disease. That's on the clinical side. On the NASH national side, every country needs to understand that there's an important liver disease. And, we know that liver disease is at least in the, one of the top dozen sort of causes of mortality in the United States and other places. So we have to address this by creating national policy for each country that could be different than one from the other country. We're just finishing up a study looking at the global burden of disease data set combined with United Nations data set and looking at food insecurity and its impact on both prevalence and mortality. You'd be surprised that when you look at what are the drivers of both prevalence and mortality, it's different than what we call the high SDI countries and low SDI countries. That's SDI is the socio-demographic index. So you have to actually understand the reality of each country. That's not only the disease, but the economic and social sort of determinant of health in those countries that we can actually address appropriately with the regional sort of side. So that's what I like to see in parallel to the clinical side. And then most importantly, we'll raise it to the global, that the global, the WHO needs to really recognize this disease as an important non-communicable disease. Like we have all said before, with kidney disease, yes, kidney disease is very important. You can live with dialysis when you have kidney failure. When you have liver failure, you don't have dialysis. You'll either die or get a liver transplant, and there's not many livers around to actually do transplant for all these patients. So it's a deadly disease, and we'd like to prevent it. So these three levels are very important to address. And then I would say at the top of all of this, although it could start from the bottom, but at the top of this and at the foundation of this are patients. We want to make sure that the patient groups, patient advocacy groups, but actual patients understand that this is an important disease, that they should become much more engaged and involved. And when they have diabetes and they go see their doctor for their diabetes and their eye check and their kidney check, they should say, are you going to check my liver or not? I think it's going to be engagement from all these sort of different stakeholders that will get us there. There was a lot of enthusiasm from the pharma companies when this disease was being promoted first in the last 10 years. But unfortunately, a lot of drugs failed just because it's a very complex disease and you cannot simplify this. And if you simplify it, you will fail in terms of your drug development. But that failure have actually sort of at least dampened some of the enthusiasm from the pharma side. But as we get the new drug approval, hopefully in March, there's resmetirom that hopefully will be approved this year. And then the drug that the GLP-1s and dual agonists that Jörn was talking about, the more success we see in the future that not only the improve outcomes, but also quality of life of patients, then we will see re-engagement of pharma that could do a lot of good for promoting this. And of course, ultimately, it's all about our patients and how we actually get our patients out of this potential trajectory.
First of all, Zobair, thanks. Fantastic answer and fantastic thoughts. I have more questions than I could ask in the next 2 hours, so let me let you guys go ahead instead of me monopolizing.
One of the sections within the paper referred to the fact that women over 55 are one of the liver transplant risks now. Is there an opportunity here to liaise with menopausal health, to put women on a screening program, rather like we have cervical screening, breast screening, particularly when they hit menopause and go through, to try and reduce that increasingly growing need that goes to transplant? Purely because we've discussed here, women don't get transplanted as often and we don't do as well. So whether or not we can pick out high-risk populations.
Yeah, absolutely. I think that should be part of the better targeted approach to different population. I mean, the algorithms currently look at individuals who have elevated liver enzyme, who have metabolic abnormalities, who have type 2 diabetes. They should be at least, risk stratified. Because as you know, and the prevalence of MASH is higher in women postmenopausal, and the progression of disease is faster. This may be related to all the metabolic sort of changes that happens postmenopause. And I think this should be recognized and looking for, especially if you look for markers of insulin resistance in the postmenopausal setting, and if you see any of those are directly connected to MASH, and those are the patients that should actually be screened, because that's probably how you could impact the burden of this disease in that segment of the population that ultimately has been feeding the liver transplant side of things. Absolutely, I think it should become a part of that care pathway.
The menopause question is interesting, Louise, also from the pathological view, because we have estrogen receptors in the liver, actually, and there's a number of groups have been exploring that in animal models. Of course, also female sex as a risk factor factor if it comes to age. And then all of a sudden, when your hormone level drop and you have that's related to the age, you're past 50, I think you're struck with two risk factors at once. And that's when women catch up with disease severity over their male counterparts, which, have been building up a little bit more slowly, but more continuously. This is something that we typically factor in with age, but there's an additional kick from estrogen level decline that feeds that, as far as I understand it from the pathophysiology also.
Yeah, I agree. Absolutely.
That makes sense.
I was just going to say, I'd like to see maybe some liver health put into some of the menopausal debates in their conferences and awareness. But we'll get there. It's the next notch on the gun, as they say.
So, Jörn, you got time on your schedule to expand your outreach to gynecology conferences?
Well, it doesn't have to be one person doing it all, right? I think there's a lot of capable people in the field. So, I think it's among the groups that we can talk to because they're treating patients at risk for advanced liver disease. Gynecologists in contact with women postmenopausal are clearly a group that we should inform about this. And, they're doing ultrasounds to a certain degree. If you identify steatotic liver disease in your patient during an exam, that would be another fit. Anyways, I think it's important to educate colleagues on it and the risk factors. And a gynecologist might as well be another group we have to talk to.
Couldn't agree more. Zobair, were you going to say something about that, or should I go on to the next question?
Yeah, no, they already should be involved in the context of PCOS, which is and the OB and GYN side of things, and those are patients with significant insulin resistance and very high rate of MASH. So yeah.
Absolutely.
Yeah. That feels like the bridge there. Absolutely.
In fact, actually, in some of the OB guidelines, actually, there is mention of MASH, and there is a section for it. This takes me back to, the Global NASH Council that I've been chairing, and Jörn and 200 other members from 50 countries are members. We have taken on this really monumental project of trying to help implement guidelines across specialties, across different parts of the world. So the project here was for two reasons. One, when you look at guidelines, there's some differences. Maybe 90% of the guidelines are the same, but 10% are different. And you don't know whether these differences are based on regional realities. For example, an NIT may not be available in some part of the world. Or is it really just different assessment of the same evidence? So one purpose is to find those differences and see which one is actually true difference that we can come into consensus through a Delphi process, or they're just regional realities. And the second reason for this project was that it's great to have guidelines, but if nobody's following them because they're not being implemented, then it's all for naught. So what we're hoping to do is to put all guidelines. I think the last count we have over 100 some guidelines from across the globe that we have put together, and the team of Global NASH Council is going through this with the 7 committees that we have to address each one of these and then summarize these in a easy to access sort of way for everyone, so that we can have the original guidelines available for people in a library that people can download, or these easy to access sort of algorithms, figures, tables that came from the consensus process that people can just print out or access and utilize. And we'll make that available in multiple different languages. That's a part of the effort of the Global NASH Council that we have. Roger, you asked me to talk about other things in Global NASH Council. So this is one project that is a large project. Just for the listeners who are not familiar with the Global NASH Council, this is a network of collaborators across the globe. We started with a few 10 years ago, and now, as I mentioned, there are 50 members, the 50 countries with 200 members, and it's increasing. And now it's gotten endorsed by very prestigious societies, including EASL, ALE, as well as a number of other country-specific sort of societies and patient societies or organizations like American Liver Foundation. The project of guidelines assessment and implementation is one. We have another one which has to do with the cost of inaction, which is what Jörn talked about. 8 countries to be assessed in terms of economic burden that's ongoing. We have what's called a mega-analysis of liver biopsies. This is, I think in the last count, we have about 40 different PIs came together to share their data, de-identified data of liver biopsies and clinical data, so we can look at the performance of NITs across the globe. We have another global survey of NITs, non-invasive test thresholds, and how they're being used in clinical practice, that a number of our colleagues, including Laurent Castera, Alina Allen, Jeff Lazarus, are a part of that study. So this is in addition to other projects that are run by the 7th committee of Global NASH Council that we have undertaken. And it's really very rewarding to see that a lot of these efforts will make a difference in terms of promoting awareness about the disease and generating evidence, not only at the local institution level or country-specific level, but then globally. But this is a global disease. This is not a single part of the world is spared. One of the things we want to do is to get more engagement from our colleagues in Africa, the continent of Africa, and also in Latin America, because in the meta-analysis process, we found that there's not a lot of data from these countries. So Global NASH Council has increased the number of membership from those areas so that we can actually give you a better idea about where's the hotbed of this disease and how local and global policies can make a difference.
So in that context, Zobair, you commented earlier about the differences between conditions in high SDI and low SDI countries. Could you elaborate on that a little bit for our audience? We've got listeners in kind of all over the globe in all kinds of countries. Can you elaborate a little bit on the differences so people can understand how their situation might be different from, say, what they read in other places?
So it's really interesting because when you look at high SDI countries, it's basically access to quote unquote bad nutrition, meaning that, very high calorie, low quality foods that are available in these countries that promote fatty liver disease. And low activity also is the driver of MASLD in the high SDI countries. And the low SDI countries, it's actually when you are dealing with food insecurity, meaning that you're actually in those countries, food insecurity is not about quality of food. It's about what you have available. It's about poverty and malnourishment. It's a different story in those countries. So when you're developing policies to address these two different aspects of MASLD in different regions of the world, you have to look at how to create better lifestyle in terms of nutrition and activities in high SDI countries and low SDI countries. It's really providing food, because a lot of those countries, it's the poverty and malnourishment that actually is driving those things. Now, in addition to this, of course, there are other things that plays a role, exposure to what's actually in the environment in terms of potential toxins that can drive gut microbiota and other things that could contribute. And so it would be really important, pollution, for example. Pollution is an important driver of diabetes that has been ignored. And actually, there are studies that our colleague Shira Zerosagi has been at least teaching us about, that pollution and even the use of services, so for example, single-use plastic bottles can actually promote these diseases. These types of education could be focused on, targeted for high SDI countries, but maybe a slightly different approach would be for low SDI countries. Part of the Global NASH Council's effort would be to develop these patient and provider information that will be on our website. So we are creating this for lifestyle. What do you do for adults in terms of what diets do you recommend? What type of activities do you recommend? And what do you do for children? Because that's really what's the tsunami is coming. It's coming from the kids because the prevalence is high and it's promoting this.
Yeah, I was just going to make a comment and basically tie it into the menopausal health thing. Women provide the majority of healthcare, but the majority of the workforce. We're also the majority of people who do the shopping, the cooking, and the preparation of food. So by targeting women and awareness of their own liver health, and particularly where children are concerned, we may actually be the opportunity to look at some of those countries that are less provided for by actually the education. It comes back to education. But I think women in their role in society and the family, if we're better educated, we can provide better and do better and be less the patient rather than the mechanism for change. From that perspective, it was just when you were talking there.
Louise, I cannot agree with you more. And actually, it may be slightly different than high SDI countries and low SDI countries, but regardless of where you live, sort of the lifestyle habit, the eating habit, and the activity habit could be influenced significantly by women in the household. And I think focusing and targeting that segment of the population would be extremely important. And I agree with you. I think this would be a very important aspect. I would say that in the low SDI countries, that's predominantly the role of women and how to educate them to address that. success. That would be an incredibly important step to take.
Interesting. The thought I'd had, and Louise, thanks, that connects, and you've said it neatly to one of the things I was thinking, is when you deal with the rate at which population is coming into this disease, right? You've got two separate issues. Number one is, can you put your foot on the hose so that you slow the rate of patients kind of at the start line? And then how do we do a better job of treating people who are at different points in the disease process? So I was going to ask a question about actually diet as a place to put your foot on the hose. I'm also wondering what the effect will be in the high SDI countries as the GLP-1s, as the incretins become more widely used for obesity and diabetes, particularly obesity, and in the States right now, particularly at a consumer level, right? These ads that we see everywhere. Do you see that as having an effect?
Yes, in terms of how to reduce the rate of this disease, I'm a big believer it has to start very early in life, like all the other, metabolic diseases. You can't really deal with obesity and type 2 diabetes unless you deal with how our kids actually getting educated about eating habits and about lifestyle. That's a policy decision that has to be made and promoted. And it is, as you know, it is extremely difficult sort of subject because it's being impacted by so many things with food industry, with automobile industry, with stress of modern life, etc. So it's very complicated, but I think that's where we need to sort of address this. Whether GLP-1s are going to have an impact, I actually think that in terms of addressing the metabolic disease, it's a metabolic sort of drug. It is not only it's not a liver-specific class of drugs, but of course that will improve things in general for a patient or a group of patients. From a policy perspective, from a population perspective, I think it'll be a minor dent in the problem we are facing. That problem has to be addressed by public health and global health initiatives, and it has to be changed by making sure that the disease is understood as an important non-communicable disease, and that there are resources at the national and global level that actually will be focused towards this. Now, I always get this question, well, if I'm in a country that has high rate of mortality from infections, would I care about disease that may kill patients, 50 years from now versus something that's going to be high? Obviously, you have to make your balancing your priorities, but amongst those priorities, in the same context that we talk about coronary artery disease or kidney disease or eye disease, liver disease should be in that priority. And I understand that a country will prioritize an infection versus a non-communicable disease, but in general, MASH has to become a part of those conversations, and it cannot be ignored anymore.
Duly noted. You're nodding.
Well, I couldn't agree more. And I think, again, Zobair has a longstanding history and experience talking to payers and the regulators based on his experience and data on the prevalence. And the Global NASH Council, again, coming back to that, has been instrumental to understanding the needs in different countries and exchanging on it, even beyond the usual context we have during the professional societies. So this has really been a tremendous and successful effort to support the field.
I couldn't agree more. And Zobair, every time we speak, I learn a ton about things I don't normally think about and probably should, given my background. We're rolling towards 1 hour kind of at the bottom. So first, Jörn, Louise, do you have any other questions? And if not, I'll go to wrap up.
No, it reminds me of, I see MASH patients every day in my clinic. And then taking this hour off, sitting back here in the evening, you could think of other things, but it reminds me that how important and how urgent it is to move the message and bring forward the message of that tsunami that's really awaiting, the cost of passiveness, not doing anything, starting with the kids, educating them, talking to women, talking to colleagues, identifying those patients, new drugs on the horizon. I think there's been really a lot of movement, and the numbers globally remind me on how important it is to act now.
Excellent. Louise, thought, and then I'll one of mine and then closing question.
No, I agree with Jörn on that. No thoughts. Everything's been said that needs to be said, I think, and we just need to get the message out there better.
So listening to you, Zobair, one of the messages I'm hearing coming out of this that I haven't necessarily thought about as much as I should in the past is the importance of teaching people how to feed their families well on limited budgets, right? Because if you talk about low SDI as being a problem of simply getting enough nutrition, then if you can align on how to maximize nutrition for low budgets, put that in the hands of the people who do the cooking, mostly women, and in the hands of governments in some way or NGOs, you might actually have a shot at putting your foot on the hose in that place. It's the one thing I'd not thought of before today. I'm sure you have, but I have.
I think in general, that's one of the message of that study. What my hope has has been over the past 25, 30 years is to just generate evidence to support our perspective about this disease that's becoming global now. And I think at this point in my career, I'm grateful to people like Jörn and Jeff Lazarus, Shira Zaversagi. There are so many other colleagues in the Global NASH Council that we are a network to really work together. This is only going to work for combating this disease if we put our egos aside and come together as colleagues and friends and collaborate across specialties, across different continents, different countries to understand this disease better, whether there's impact of food insecurity, whether there's impact of disease on economic burden or quality of life or clinical outcome, to generate that evidence, because only with that type of approach that then we can convince the policymakers, at the national level and at the global level of the WHO that this is an important disease, and we are as one field unified globally to move forward. And I think we're doing this with help of colleagues like Jörn and others to move our field forward and get attention. And I think we are getting some attention at the highest level of policymaking in the United States as well as WHO and other places.
Fantastic. You know what? I don't know that we need a closing question. So, Bear, I think that statement might suffice to end the whole conversation right there, unless anybody has anything they want to add.
No, I appreciate you giving me the opportunity to talk. This was wonderful. Thank you.
Fantastic. So I will be back with the question of the week, which will actually have to do with this conversation, and then business report. For everybody else, let's all just say goodbye. Zobair, thanks again. I hope to have you with us soon, and look forward to seeing you out on the road somewhere.
Thanks very much.
As the year progresses.
Thank you.
Thank you.
Good seeing you.
Take care.
Bye-bye.
And now, here's Roger with our first question of the week.
Hi there, here's our first question of the week, and here's how it works. I'm going to ask a brief question, and then after that, we'd like you to reply either in writing or via audio or video, whatever you wish, by sending it to QOW@surfingmash.com. We'll use the best answers next week and maybe even invite you to join us. So here's our question. On this episode, Zobair Younossi and the crew talked about the need to raise awareness of MASLD NASH in all its different elements and what it means in different countries around the world. What is one thing that you can do that is not part of your day job that will have the effect of increasing awareness or helping people with disease get screened and treated, or otherwise improving global consciousness of this pandemic and everything we need to do to get in front of it? Can't wait to hear your answers.
And now for the Season 5, Episode 4 Business Report.
Slava Ukraini, glory to Ukraine, and also Am Yisrael Chai, the people of Israel live. I know we're late in the month of February as I record this, but it feels like Groundhog Day in the U.S. Capitol. No movement on Ukraine, no movement on Israel. Instead, the House takes a 2-week vacation from their hard work doing not much and not passing legislation. Then, I listen to President Zelensky speak to world leaders, and I read about the bravery of Israelis willing to stand up to their own government in support of the hostages. Courage is in short supply in many places, and the U.S. Congress is doing its best not to reward those who show it. Sorry I'm such a downer about this, but it gets frustrating sometimes. Well, next week will be better. Heroyam Slava, glory to the heroes, and also Am Yisrael Chai, the people of Israel live.
Thanks for complimenting our influence.
It's gratifying to us that downloads continue to grow again. Even better news are the 3 outreaches we've received in the past week from folks who want to work with us or appear on the podcast due to our, and I quote, extended reach and influence in this community. Thanks to the listens, likes, compliments, and overall support. You people are the reason we do this.
Our first question of the week appeared a few minutes ago.
If you made it this far into the episode, you will have just heard our first question of the week. As I mentioned during that section, you can reply by sending a note to QOW@surfingmash.com or by clicking the link on the video post you see for the question. I can't wait to hear what folks have to say.
We're working on our next 2 weeks of topics right now.
As I write this, we're working on an episode next week focusing on NITs and one the week after looking at payer issues. That episode will drop on March 13th or 14th, around the same time as the Rosmita on PDUFA date. I'm working on post-PDUFA episodes and cast right now as well. You'll hear more about that next week.
This week's Vault comes from a 2022 Epidemiology episode.
In 2022, Chris Estes, then the lead modeler at the Center for Disease Analysis Foundation, joined us for 2 episodes about different aspects of epidemiologic modeling in fatty liver disease. This conversation focuses on what we can learn from modeling about how to classify and treat patients, and also what we can anticipate globally in terms of disease growth. It's a different take on what Zobair Younossi was discussing today, and even some different foci, but still thought-provoking, so enjoy. All right, that's it for this week. I want to thank our team, Jörn, Louise, Mike, Eric, Steve, as we keep moving into 2024 and await what we think will be an exciting year still ahead. Enjoy our conversation Saturday, Sunday. Please take a listen to the question of the week and, of course, reply. We'll be back next week. Until then, stay safe, surf on. Bye-bye now.
Have any questions for the surfers? You can send them to questions@surfingmash.com and we will answer on the podcast or website. Your question might even wind up being the question of the week.